Lori Roscoe has become a friend over the course of the last year, and has been involved with these presentations through her involvement with the ACNA, the American Correctional Nurses Association, a wonderful organization of nurses who is doing really, really good work. Please mute, everybody, please mute. Appreciate your muting. So at any rate, I encourage you, any nurses in the room, think about joining the ACNA. It's a great group. I was at the National Commission about, well, it was 2 years ago. I was at the National Commission. I ran into Mary Muse and a bunch of my nursing friends from back in the day, and they told me about the ACNA, and I was shocked and thrilled to hear that they had finally done what had been spoken of multiple times in the past, and formed an independent nursing association for corrections. I'm thrilled. They're a great group, and I know that Lori is the Lori who will be moderating this. I'm going to try and fall off into the background here. Lori, who will be moderating this, is the treasurer of the group. We have Annette Maruka with us, who presented the last time on wellness issues for correctional providers. And I'm just very happy to have the involvement of the ACNA in these programs. Mary Muse is here and is going to present a case. And Mary has been. Are you still the president of the group, Mary?
She is.
Yes.
Yeah, that's what I thought. So without further ado, Lori, I'm going to ask you to say a couple of words about the ACNA and introduce yourself. If you want to introduce information about your blog or any of the other things that you do, feel free. And otherwise, then let's just get started. I'm going to go mute.
Well, I appreciate that, Mike. I will not advertise what I do other than to say, hopefully, my career now is supporting correctional nursing throughout the United States. I would encourage all of you here to please go back to your nurses and let them know, if they don't know, that there is a national organization for correctional nurses. As I said before we started, we embrace and have as members LPNs, RNs, and advanced practice registered nurses. And this is unique to our organization. I don't think there's any other organization in the United States that has all 3 levels of licensure as part of their membership. And so we're really proud about that. And we value everyone's input, from LPNs to RNs to APRNs. So please go back to your sites and let them know that there is this organization available to them. As Mike already said, I'm Lori Roscoe, and I'm here to moderate the session for this evening. I welcome you to Compassion and Care, War Stories from the Trenches. And then, of course, the, in parentheses, case histories of correctional medicine. We are not in war, thank goodness. Although some days when I go home from clinical, I think that we might be. We have a number of wonderful people who have volunteered to speak today and present cases. But I also want to encourage those of you in the audience to think about presenting the next time. It's clear already that this is something that people are interested in moving forward. And I haven't spoken to Mike about it, but the feedback that I received this past week when I had asked for individuals who wanted to present was that, no, I can't do it now, but I really want to do it in the new year. So hopefully at least 1 or 2 of those sessions will be similar to this evening's presentations, which again are individual cases. I have a list of people's names who volunteered before the session. And as we get on with it, if we have extra time, which I doubt we will, but in case we do, if there's anyone in the audience who would like to share information or a case that they dealt with, please feel free to let us know. And if we have time, we will certainly put you on, or else we will take your name and put you on for the next time. Our first presentation, and actually he has 2 of them for us, is Dr. Niki. So Dr. Niki, without further ado, why don't you go ahead and start?
Thank you. Thank you for the opportunity. My name is Mike Niki. I'm Chief Medical Officer for San Bernardino County Department of Probation. So for the past 10 years, I've been taking care of the juvenile and young adult. In this case, two cases are related to um, some of our cares back there. Case number one is a 14-year-old Spanish female, very petite. I see her on a Friday afternoon. Everyone hear me good?
Yes.
Yeah. Friday afternoon, I see her in a high desert, which we have a little facility back there. And she had this flat effect, but everything on the physical was okay. I knew that there's some psychological issue. Her past medical history was indicated as major depression, suicidal attempt, self-mutilation, and also this particular time, she also had a homicidal attempt, and that's why she came into the system. So I took care of her, and there was a vague history of meningitis when she was age 9. That's what I heard, and she's 14 now, so 5 years prior to that. I just requested her past medical history and documentation from the regional hospital where she was treated. And, I go to my second facility, and lo and behold, about 16 hours later on Saturday afternoon, I hear from one of my trusted nurse. Pat calls me and says, "Hey, doc." And I work with Pat in trauma because I'm actually a ER trained, flight trained, and work in a trauma center as a ER physician too. So he said, "Hey, doc, I've got the kid that you remember you saw yesterday. Yeah, she now has aphasia, has a left facial droop, has headache, and she also having a slurred speech. And after you see your patients, you kind of develop that trust. I mean, not everybody, you have to categorize sort of like being pretending or malingering or things like that. I've seen stroke in age 2 in ER. So what I told Pat is just call code a stroke and transfer it to closest hospital. She goes to closest hospital. They do a CT scan. And the physician from there calls me and says, "Well, I see a mass in her brain. And it looks like she has a large tumor." And I'm like, "Okay, well, don't send it to county hospital where I am because we don't have a pediatric ICU. Send her to the pediatric hospital." So she's flown there. By the time she gets there, her mental status deteriorates. She's now having total left-sided hemiplegia, and she's having a seizure, 2 episodes of seizure. So they do RSI, intubate her, give her mannitol, hypertonic saline, and she goes to the floor. By next morning, I was there. I talked to our parents who spoke Spanish through a translator, who's my manager. And we basically sat down there and dig out a little bit more. She was actually in that particular hospital when she was 9 and was treated for that particular case of, so to speak, meningitis. So about an hour later, they finish the IV contrast CT scan. They do a MRI, regular MRI. It doesn't look like a typical tumor. So the neurologist, pediatric neurologist is there. We discuss about it, and then I tell her, "Look, this patient was here before you guys changed the your new medical record system. So you might have to dig out the papers because it hasn't been transferred to us." Lo and behold, we go in and we look into it. It actually wasn't meningitis. It was actually a mycoplasma encephalitis. So she had a case of encephalitis earlier, and she was put on a steroid, but she was undocumented, didn't have any insurance, parents were undocumented. So she basically, from age 9, started having depression, flat effects, suicidal ideation, psychiatric problem, one after another, from that organic cause, which never followed up with anyone. So they do LP, and lo and behold, it shows actually that in CSF, she had a mycoplasma IgM. Then we started heavy dose of steroid treatment, immunoglobulin therapy, and then also plasma exchange for 3 days. By 3rd day, she actually got extubated. I saw that her progression. Immediately, I went back and started talking to my manager about her case that, hey, this mass is probably causing for all her psychiatric issues and also correctional issues. So we got together with the district chiefs and deputy chiefs of the probation. We wrote a letter to the court, and I described that, because the mass was like quarter size of her dominant side, pushing into the frontal parietal area. And there is actually, I encourage you to look at it because I thought that it would take too much time when I load and unload. There is an image on the MRI T2 that you can look at it on Google. Look for what they call leopard skin sign or tigroid pattern, which is basically an antibody that goes inside the white matter. And that pattern on a T2 image is very representative of what she had, which is basically a acute case of disseminated encephalomyelitis. So what happens is basically you have like your inflammatory cells like T cell and macrophages attacking the endothelial cell of the white matter in the brain and the dark matter in the brain, entangling themselves, forming a mass, and that eventually pushes slowly to get where that event happens, which is basically mental status changes and stroke symptoms. So anyway, we actually successfully were able to get her out of the correctional system. Court released her, and before she goes home, before she goes home from the hospital, I gave my card to her dad and said, just follow and let me know how she does. That was October of the year, and then about January, just about Christmas Day, I get a call from her directly on my cell phone and thanking me about, my dad told me that you helped me, so I wanted to thank you. I get very emotional talking about it. But she continued on the school, and I followed up. Actually, we published this case in 2019, and as of last year, she was still in the school and they were doing great. We follow up. I have very strict rule on really communication with my patients, so they are free to call me on my cell phone. So her case was basically acute disseminated encephalomyelitis. I published this case because I never even heard about it when I was in medical school and 20 years of practice. And nobody in the hospital seen any of that. It's 4 in 100,000. Most of the publication, the good one, the old ones came from Israel, where they did a brain biopsy to analyze those T cells and macrophages to figure out what it is. But nowadays we could actually do LP and also do a T2 imaging of MRI to take a look at it and be suspicious about that disease. There is only 3 clearly white matter inflammatory disease that exist in acute setting. It's either ADM, it's either optic neuritis or MS. And none of them present like this. In MS, the youngest patients I had was a twin 17-year-old sister, African-American, with some sign of upper motor neuron. And I did MRI like acutely and found that, of course, they had also some lesion on CT scan. Optic neuritis was the same way. I did MRI and I found it on a 26-year-old female. But this case was very unique. I've never heard, and I bet if I put it out there, I don't know. Yeah, go ahead, please. Mike,
yeah, it's a great case, and I'm a little bit embarrassed because I really bugged Michelle Staples Horn because, as far as I knew, she was the only person who could present a good pediatrics case. And here, you've got a fabulous pediatrics case, so I appreciate it. I'm going to jump in and just say that one of my purposes in holding a meeting like this is to have us together discussing cases. The other is that I think we have so many good stories in corrections that I think we need to start thinking about a book of stories out of the correctional logbook. The final thing I want to say, and I'll go to mute, and we'll hopefully go to another case or get some comments. Is that never mind for later.
So I'm gonna stop on this case right here and just put it out there if there's any questions, so I can get to the specific if we need more detail on that. I will send the case because it's basically pediatric emergency medicine that published, and they still have it as you have to pay and read it. But I have a copy of that. I'll send it to Lori to send it to everybody here if you're interested to. Yeah, go ahead, please.
Thank you.
I can help with that, Lori.
Yeah, no, thanks so much for presenting. That's a great case, and thanks for your diligence.
Yeah, very unique. I don't know, any of you guys actually heard this thing before, like in your career? ADL? Yeah, it was very bizarre. I tell you, I did a extensive literature search, and even in my hospital, I could challenge the entire physician and staff, and nobody would know anything about it or see anything. It was very unique, I would say.
Doc, takeaway from that. I'm not juvenile, I'm adult. My patients are adults. But I always tell my nurses to make sure there's not an organic issue with the patient before they just discount them as having a mental illness. And your case just kind of brought that to home, because I think I heard you say that a lot of her issues were the result of this inflammation, not so much as a mental illness that started out that way. And so I think we have to be mindful of that as well when we take care of our patients.
So Lori, it changed our culture actually. This case actually changed our culture drastically. Not only in a, because I'm involved also in adult jail care with my partners, and I'm very, and also the education of residents, because I'm director of research and tactical medicine for our residency program too. So all of those now have this perspective that, hey, make sure it's not organic cause. Before, these one imaging study, one thing, one decent lab before you mark those guys as being, that. And number two is my past history. I was a political prisoner in Iran before I escaped that country. So human rights is priority for me, and I'm very passionate about it. So that really triggers my drive into looking at, equal right, human right. Many of us in outside the United States don't even know what human right is, or we never had that. So,
well, a lot of people in the United States don't know either, but I'll stay away from that. I really applaud what you're doing. I do remember back in the day, 100 years ago, when I was in medical school, the chief of medicine would send us three junior medical students, third-year medical students, into a mental health ward and said, don't come out until you find an organic disease for the problems that are going on there. So that was really an education.
Yes, I miss that old teachers. We don't get that anymore.
All right,
Go ahead.
Oh, we've got people in the wings. Here we go. Thank you.
So would you like me to present the second one? Or you want to give the opportunity?
I think let's give other people a chance. What do you think, Lori?
Yeah, if that doesn't mind, just save that one, Dr. Niki, for our next panel discussion. Really.
Please.
Absolutely. Thank you so much for the opportunity.
Thank you. Can I call on someone, Mike?
Yeah, I wish you would.
Okay,
Yeah.
Renee, do you have a case for us? This is Renee Daring.
Unmute.
I do. It's not as medically exciting, but I think it was just kind of interesting because of how in this particular one, we had to work with law enforcement.
Renee, introduce yourself. Tell us.
Intro.
I'm Renee Daring. I'm a nurse practitioner. I've been in corrections since 2001. And I'm family practice, so I see all ages. So anyway, this case is, like I said, it's not medically exciting. It's kind of simple in that respect, but it was interesting how we all kind of had to work together on this particular one. This was a kid, I say kid, but he had just become an adult not too long before he came into custody at the jail that I worked at. I knew him. Unfortunately, I knew him from coming to juveniles several times, and I covered the juvenile center as well. And he had been involved in, when he graduated to the adult jail, he had been involved in a pretty high profile case on the outside. It was some sort of gang shootout or something. After all these years, it tells you how long I've been in corrections. I don't even remember the details of what the whole case was about. But anyway, they brought him down to see me in clinic. He'd been in the jail about a month. And he said to me that he had a bullet coming out of him. And I know that he had been, after this altercation or whatever it was in the community had taken place, that he'd been taken to the ER and, you know, been patched up and so on a month ago. So it was, you know, kind of interesting. So he showed me, and in fact, he did, kind of right at the crease of where his upper leg met his butt cheek. There was a bullet emerging, and he didn't know. I think he said that he had tried to tell him in the ER he had been shot there too, but I don't know. They said they didn't listen or whatever. So it was clearly emerging, and needed to be removed. And so because it was a very high profile case on the outside, and we're a detention center, so he hadn't been adjudicated yet. I talked with our officer in the health service, and he consulted with our police department, and they wanted obviously to have this as evidence. So I took the bullet out, made sure that, because I kind of wanted to be kept out of the legal piece of it, I made sure that the officer witnessed the bullet coming out, because we had to kind of have it documented every step of the way. I took it out, turned it over, we bagged it or whatever we did with it and labeled it and so on. And during the time that I was doing that, by the time I got done, the St. Paul, which is the city I'm in, was at our front door waiting to pick up the evidence. So I just thought that was kind of interesting how that kind of all intersects and how you have to work together. And it's probably not something you see in other types of practices.
So Renee, did you have policies and procedures around that on that process, or did you kind of have to invent the wheel there?
We had to kind of invent the wheel. I mean, I was there for a long time. I was 15 years there, and that was the first time anything like that had come up. But again, because it was a very high profile case and an active investigation, they wanted the evidence, and we had to be sure that officer that worked with us in health services was fantastic. He was an ex-Army guy, and he had gotten down all the information from them about how we had to maintain chain of custody and so on, so that they knew, you know, that it had never been out of sight of anyone. Interestingly enough, the kid didn't seem all that bothered by any of it. I think he later ended up going to prison. Unfortunately, we had a run of graduates from juvenile who ended up in some very, very bad crimes that for a couple of years and ended up going off to prison. Somebody's asking about being surprised that we were allowed to collect forensic evidence. You know, that was part of the thinking about it. It was very superficial to be able to take out. And we just didn't see, since I had an officer there with me, any point to sending him to an ER to have this done and paying all that extra money, because we were certainly capable of meeting the standards that they needed for it.
And I think forensically, as long as we get the person's informed consent to do it, then that we're okay with that. I think the standard is pretty clear on that.
Yeah, was the kid aware that you were going to use this, that you were going to hand this over as evidence? He knew. Yeah.
Oh, okay. Yeah. Because the officer was in there. I mean, the officer didn't like watch the entire thing. He kind of made sure that he just kind of saw, you know, enough to know that that's where it came from. You know what I mean? It wasn't like he's just standing in there gawking at the whole thing.
This is an important case. This is an important case. I mean, for that very reason, because if he had refused, you did a procedure based on a medical need. Period. Yeah. End of story.
Right.
People collected that evidence from you, but you did a procedure for a medical reason. I'm really interested in any other point counterpoint on this. Does anybody think differently about this?
Well, and I think part of, like I said, I'd known this kid for a while, and maybe that was, part of my ability to just be frank with him and tell him, we have to send this to the police department and so on. And because, like I said, he just didn't seem to be very concerned about the whole thing. In fact, he was kind of, I remember that he was kind of joking with us and asked
So
me,
here's a question I have. So
Mhm.
he was told that this was going to go to the police, so it'd be part of forensic evidence. But was he consenting to that? And
Oh,
it
yeah.
kind of raises. So here's, and again, I wasn't there, I don't know the story, but here are the concerns I have. Did he understand what he was consenting to? Did he really understand? Because a teenager saying, yeah, sometimes they think it's cool, but it's not cool. And then the conflict or the tension between the role of the health provider and then the role of custody arises. So that's just my comment on it. I think it's a kind of a thin line.
Well,
If I,
and interestingly enough, like, I think everybody's assuming this is going to be evidence against him. He didn't shoot himself.
Right, it was for the other.
Maybe he's
But-
thinking this is helpful to him.
but Mary is correct. You still need a consent because this is not a life-saving procedure.
Oh, yeah,
Number
they had to do
two,
written consent for any sort of procedure.
right.
Yeah, I just
In-
think it raises some ethical issues. I mean, if it helped him, I'm happy about that. But I still think that it really creates that tension with what is the role of healthcare providers and being caught in. And it may have been, obviously, it sounds like it was a situation.
So
that you were
interesting.
caught in, but
Interesting.
just the
We often get, when I'm in ER, about 10 years ago, I had the first trouble with a sergeant that comes in with a correctional patient and a letter from a judge that wanted to take something off the rectal wall. And flat out, I said, "Sir, are you allowing us to do that?" No. I said to the police officer, "Oh, we can't do anything. You can tell the judge to do that then, because I have no consent." He threatened me to arrest, but he didn't know who I am at the time. He was a medical director for a member of the police department. So conflict got to a point where we throw him out. The guy, you can't do that. That's assault to the patient. Number two is a direct custody of the evidence. You can't be in a room alone taking something without a police officer or a custody officer be there to take it from. And that's obviously, I agree with Mary, all of that has to be in agreement with the patient and consenting. This is basic human right. We're not a enforcer of custody. We're basically medical side, no matter what they tell you.
True.
Yeah,
I put a picture of it
have
in
I'm sorry, I
Yeah.
don't want to interrupt. I did have a patient with a bullet in his shoulder that was causing him problems with his brachial plexus, and he absolutely refused to have it taken out because he said it's going to be evidence and I don't want it taken out.
Interesting. All right, well, thank you, Renee. Your case was very thought-provoking for everyone. And again, I think that we need to look at our standards and we need to determine, again, what an informed consent would look like in that situation. And then, think about it in advance of when you're put in that situation, so that if that were to happen at your facility, what are the steps that you would follow? It's so important to have that written down so that it can be referenced, should that ever occur. Is Dr. Staples-Horn here?
Michelle is not able to make the meeting today, and I think that since we've had, I don't, how old was this kid, Renee? You said kid, but I think I got the idea he
Yeah.
was a young adult, not a juvenile.
He had to be at least 18. He had grown out of the juvenile
Otherwise, he
system.
wouldn't
So
be in, yeah.
I'm saying he's 18 to 19, best than I can remember. And interestingly, I never got called into court or anything, but again, my thought was that I'm going to let the officer witness this part You know, so that I don't become part of the legal proceedings. I'm just doing the medical part. But
I think we need to be real clear here because there are comments in the chat. I'll jump in, and it just says, what are the policies in various states? The National Commission policy, the standard from the National Commission says we're not supposed to be involved in the collection of forensic evidence, period, full stop. Okay, in this case, the borders are blurred on whether this was forensic evidence or not. It wasn't necessarily forensic evidence against this kid, and most importantly, I'm quite sure that this did not significantly contribute to convicting him. He was shot by somebody else, but I mean, who knows? But nevertheless, I want to be clear on what the National Commission standard is, since there's some discussion about what the standard is in various jurisdictions. It doesn't matter. The National Commission standard is very clear on this.
so how do you,
I think
my
it was an
question is, how do you kind of sort that? Because when I think about that, I think about seeing them only to collect the forensic evidence.
Yeah, that's
because
right.
this
That's
is-
why I say this was vague. This was on the
Mhm.
edges of this question in a sense. But yeah, I think that yeah. So you're right. But in the bottom line, I think, Mary, I think you'd agree, and Laura, you'd probably agree also, that this guy, if it was evidence against him, and or if there was not a reason to remove this bullet otherwise, then he should have gotten taken by the police to the emergency room, to another facility out of your jurisdiction to have this done.
My other thought, though, yes, I would agree to that. My other thought is that even if there was a need to remove the bullet because it was a life-saving measure or prevent further damage, I guess I would have the police have to go through my legal department, or they would have to go get a court order because I'm not turning something like this over to them directly. So I would have to contact legal because of our standards and me, because once I'm removing it, because what the police person is documenting is that they now have this bullet that's forensic, you know, whatever, for whatever reason, whether it's for him or against him. And so you are part of the legal proceeding. Should it may not go any further than what happened that day, but if it could, you don't know that to 5 years later, 3 to 5 years later. So because it puts me in a position, and I know our standards are that we don't participate, I would say, so I can't give you this. I am going to save his life because I need to do that. But you will have to go through our attorneys, and that part has to get handled somewhere else. So that I'm not part of that.
So then would you retain the bullet somewhere?
So that, and again, I'm gonna call legal, so it probably would get retained. I would, I wouldn't be moving it somewhere else, but I'm not gonna directly, based on what I understand about standards and the rub there.
Yeah.
I would document it and communicate to legal.
Question for Renee: how did you pull the bullet out? Like, how did you touch the actual metal brass part of it?
Oh gosh, this is like over a decade ago. That's what I'm trying to remember.
Typically, we don't recommend putting the direct metal to metal. We use a 4x4 or some padding, because that basically changes the groove evidence, by the way, if it has to happen. We do a lot of that in our trauma center. So, so we do forensic, forensic profiling, and then work with the forensic folks to that. So you really, what we teach our residents and stuff is that metal should not be grinding on a metal, because you will change that pattern that they are looking for, which because is a pattern of barrel, and each gun creates one DNA.
Well, if I remember right, it as you can see in that picture I put in the chat, it flattened out,
right.
when bullets do. So I think I had to use my hand, because it kind of was a stinker to get loose from the tissue, kind of.
So the bullet that you put down there looks like a hollow point. which is sensitive to water, opens up like a flower when you hit it. It was designed in 1960s, but caused havoc. And then they basically took it off the market, and it's actually only used by majority of the time is used by law enforcement.
I was gonna say, he may have been shot by a cop too, so, you know, well, we're all thinking this is bad for him, maybe it wasn't, you know?
So I do have a case from Michelle, but we've already had two young people, maybe a different case, and then I can always present Michelle's. Unless you want me to, Lori, unless you want me to, because I think I can be done with it in about 5 minutes, and it makes a point.
Sure, and I want to hear your case as well. You said you had.
Okay. All right. Well, let me think about whether I want to present mine, or let me do Michelle's. It's quick, and then let me be thinking about my case a little bit. You've got a 15-year-old kid in your clinic. He wants a COVID vaccine. His mother absolutely will not sign for a COVID vaccine as a non-vaxxer. And the kid says, I want it, I want it, I want it. I think I'm going to protect my own health. My mother's a jerk. What do you do? And the answer is that Michelle had to, and this comes up all the time in juvenile, and that's why Michelle wanted me to make this point, even though she couldn't make it here today. The point is that the mother has to give consent. The child is 15 years old and is not emancipated and does not have permission to give own consent. And so while the patient assents to having the vaccine, agrees or assents to having the vaccine, she can't get the vaccine without her mother's consent or without a court order giving her permission to call for her own health care. Like it or not, that's the rules. The second case that she gave me was the exact opposite, where the mother said, I want my daughter to have a chickenpox vaccine. I know she didn't ever have chickenpox. I don't want to see her get sick and wind up in the hospital. I'm really concerned about my daughter. And the daughter absolutely would not allow it. There was a signed consent by the mother who insisted that the nursing staff hold her daughter down and make her take the vaccine. And once again, not possible. The patient has to assent to the shot, otherwise it's an assault. And even though the mother has given consent and it's a valid legal consent, the patient has to assent. You have to have both. And I think Michelle wanted us to at least have a brief conversation about this, mostly because she's, as the medical director of juvenile in Georgia for all these years, she's run into this problem ad nauseum. So any comments on that? I think I kept it under 3 minutes on Michelle's case, but I think it's a good case. I think these are both good examples of the kinds of difficulties we run into in corrections that are potentially much different from cases in the general community.
Well, you hold the child down if they're a baby.
Yeah.
You know,
True.
if they're 3 or 4 or 5. And they say, I don't want it. You say, well, you're getting your shot anyway.
There's truth.
I think the courts see it a little differently coming from a pediatric nursing background. And I was going to say Michelle's cases really bring me back to my pediatric experience, and so and then sometimes I know in jails you might wind up having kids who are younger and yet they're in the jail because sometimes they misrepresent their age, or sometimes the judge makes that decision because of the level of crime, and then that's where you really have to have heightened antennas and be advocates for youth.
Any other comment on that case from Michelle? And I'm going to give my own case a little bit of thought while somebody else presents another.
Mike, I just have a comment. Many years ago, when I was a health service administrator, we had a situation similar to what Mary just spoke about, where we had an underage person come into the DeKalb County Jail. And so obviously we had all these housing issues that we had to deal with, but he very quickly developed appendicitis, and he ended up going to the emergency department at Grady. There was a huge issue with regard to who needed to give consent for the surgery. And at that point, and again, this was almost 20 years ago, but at that point, it was determined that the sheriff had to give permission because they were the authority over the jail. And because this kid was incarcerated in the jail, he superseded the rights of the parents, for example. And I remember to this day, people were questioning the validity of that court order, but it actually ended up having to be a court order. And then, you know, he was able to get the surgery. Now, I guess you could argue that it was really potentially life-saving surgery to get that appendix out. And so therefore, kind of didn't even matter whose permission was needed. The surgeon needed to do it, and that was it. But that was also a really interesting situation, but it did have to do with an underage person in an adult or in a jail that didn't have juveniles there. So that was interesting to me. And now go ahead with your story. Oh, no, you didn't want to go. Mary, you have a case for us?
I do have a case. I'm going to try to shorten it because it was longer, and parts of this, a lot of the story is real, but they're a combination of several settings, including some of my consulting as well as some of the places I work. So it has to do with a 22-year-old male who is housed, and he has a history of sickle cell disease and asthma. Prior to his incident, he had been hospitalized maybe a week before for a pain crisis, came back to the institution, and now a week later, he was complaining of pain and was initially put in a health service request, but did not hear back on his health service request. And as his pain was increasing, he talked to the custody officer. And initially, the custody officer said, well, initially the custody officer had put in a request, but he said, I put in one. And so as he continued to complain, the custody officer then took him to health services, where they took his vitals and said his vitals were normal. And so they sent him back basically to his cell. He continued to complain. So a couple of hours later in the day, he was brought back down to the health service unit, seeing at that point his heart rate was maybe about 100. His O2 sat was 94. The nurse did talk to the doctor, but in the conversation with the physician, there was a discussion on that a couple of days ago, he was out seen on the yard at rec. Now he's complaining of pain. He was just in there a week ago. The concern was, well, is he drug seeking? Because, and also that his SID rate was normal, so therefore he couldn't be in crisis. And that the day went on basically for this young man, and his pain got worse. And then the doctor, now we're into the evening, and the on-call doctor said, well, let him get Tylenol off the commissary. If he continues to have pain, I'll see him tomorrow. And when tomorrow never came for this individual. Basically, by 8 p.m. that night, they were calling on all available in terms of the custody officers and health staff. He went out to the hospital, and this person died.
From what?
And so he died. The autopsy, vaso-occlusive crisis, stroke, and I think it was one other thing. Let me see where it is. And then there was one other part that was a part of the
Probably pulmonary emboli, because that's the most
pulmonary emboli. Yes, that's what it was.
Yeah.
And I present this case because I've seen it a couple of times, and I think it speaks to, the title of this was Compassion and Concern. I think it also speaks to health disparities and it brings up some ethical issues and the need for moral courage and advocacy, and kind of not blatantly applying perceptions to all patients. So that's it.
Yeah, it's such a huge issue for us.
I trained in Toledo, Ohio, and I had a large population of sickle cell, African-American population there. So you learn quickly to respect that. They call it actually acute chest syndrome. So they keep complaining about chest pain, shortness of breath. Their SAT will be okay. but then they throw a big clot and they're done. Like, it's just terrible disease to go through. We actually, before I take over this, I'm not even sure if I can share that thing. But anyway, before I took over this contract or become in this position, they had a patient that they sent to me who was 17-year-old, huge, tall, beautiful guy. And shortness of breath, they blow him off for 3 days. And he comes down there, I take him through CT scan, 2 o'clock in the morning, I'm in ER. And I see a large PE waiting for him. Take him back to the bed, send him to neighboring hospital tomorrow morning to do a retrieval because the IR procedure was new. And he coded on the table. We reviewed that, and it's same thing. Just why do you not consider something else? Like, why is accusation first and then medical care second? Why is it that in your eyes everybody is pretending unless they're not pretending? That's the issue, that is stigma. I don't know how we can resolve that in the medical community, but that's.
And the other piece I feel too, and I agree with everything that you said. The other piece is a lack of knowledge about sickle cell disease. I don't know how many times, because in my pediatric background, I work with kids with sickle cell, and that's how I actually learned. And then I was getting my master's, even though it was in leadership, I did a minor in med surg. So I looked at sickle cell and compared how patients with sickle cell disease were managed compared to someone who was an oncology patient. And so I also know that we tend to we hear things like the SED rate, or they don't have a temperature, so therefore whatever they're complaining about can't be real. And it has nothing to do with them being in crisis. So it really leads to, I've seen actually in the last couple of years and through the years, some outcomes that haven't been good, and also some opportunities that we had. So that's kind of why I brought it forth. Dr. Tutu, I thought I saw your hand up.
On mute.
You got to
Okay.
unmic yourself.
Yes, I think you brought up an interesting case. And sometimes we forget that patients have other underlying conditions. In 1980, I published an article, the first sickle cell patient with symptoms in the mandible. No, maxilla, I'm sorry, in the first Nigerian dental journal. And the case was shrouded in secrecy because of beliefs, family beliefs, and other things. And we had to look beyond that, because one, you will never find it in maxilla. If anything at all, it will be in the mandible. And this was the first case we published. And so you have to, and we have a unique opportunity to look at the patient as a whole, because as a dentist, this was rare and for a sickle cell crisis, and it happens with our patients. So just looking at the usual case, go beyond that and look at the disparity in the racial profile of the patient, and we may be able to. And the cases that have been presented so far, one thing has come through to me personally, is that we go beyond what somebody on the street would have considered. And that I appreciate the efforts that all these presenters have brought out, that we are going beyond the pale to just take care of our patients. And I appreciate what Michael had said and what Laurie and others have presented. Thank you.
Thank you. I think sickle cell has come full circle. I also started in the emergency department many years ago, when they called it the emergency room instead of the emergency department, because it was one room. And, you know, throughout my time there, there's definitely prejudice against sickle cell pain. There's a lot of disbelief out in the greater community. And so unfortunately, that trickles down into our staff in the correctional site. And I think education is the most important thing. And it's a gift that we give to our patients, but it's also a gift that we give to our staff. And they need to be aware that somebody coming in with sickle cell may have a normal SED rate. They may not have, you know, a bad oxygenation at this point in time. And when they do start to crash, that's too late. And so we really need to educate our nurses and some providers as well on the clinical manifestations of, for example, sickle cell. So thanks, Mary. That was a good case. Michael, we have 9 minutes left. Do you want to?
I can do a quick case in 9 minutes, and maybe we'll go over. Does anybody else got a case before I go?
I have one, but I'll save it for next time. That will ensure that we have a next time.
And I gather from the group that this has been a good discussion, and that it's a good idea for us to hold these periodically. Am I right?
Great
Say something in
discussion.
chat or say hello or whatever.
Yeah.
My case is not made up, but I have to make up the details because I didn't look up the details last night to make this case happen. The bottom line is that this is a 35-year-old Black man. He does not have sickle cell disease, but he does have ulcerative Crohn's disease, and he does have a problem with coagulopathy. That is, he's diagnosed as having a portal vein thrombosis, and he's on anticoagulants. He's on warfarin. He's on multiple other medications, but he's on warfarin. He really hates prednisone, and everybody wants to put him on prednisone, and he's not on a biological, despite the fact that he has active Crohn's disease. So right off the bat, we have issues around this guy's medical care because he has active Crohn's disease documented, and a clot in his portal vein for which he's prescribed warfarin, and which he is refusing. He's been on warfarin on the outside. He has problems with it. He's a difficult stick because he's been an IV drug user. They're demanding weekly INR testing, and the INR testing is all over the board because he doesn't always take his warfarin because he doesn't like warfarin. The provider sees him, and despite the fact that he has a documented clot and active Crohn's disease, he says, you have to just take the prednisone and the warfarin and do as I tell you to do. Okay? And so eventually this goes on for weeks and months where there's a piss and match, excuse me, but that's what it was, a piss and match between the provider and the inmate patient about what his care should be. There's never a discussion at all about various options, including no biological was ever offered to him, and the newer anticoagulants were never even spoken of or offered to him in any way. So the case is, and he had a bad outcome. He didn't die. He wound up in the hospital with a clot where he lost a bunch of gut, and was he lost literally feet worth of gut in his small intestine. He was in the hospital for over a month. He was septic. He nearly died in his mid-30s. I see this case mostly as being about what the components of an informed refusal are, and I invite comments. We've still got time for discussion, and I prefer discussion or questions to me speaking about this case. What I can tell you, and it's a settled case that I worked on, is that this guy got a settlement. I saw it as a small settlement, very small settlement, given how much he suffered and how poor his care was. But the reason it didn't come to a bigger settlement was that he was offered a treatment, and that treatment alone, prednisone and warfarin. And anyway. Comments?
Quick question for you. How old, like, this is before we have factor DNA?
You're breaking up a little bit, Michael.
Okay, was this a old case? Like, I think somebody needs to mute it because we have this feedback.
Somebody not mute. I'm gonna mute the one person I can see.
So
and
let
I
me
go ahead.
How old is this case? Like, is it before the factor 10 being in the market, factor 10 inhibitors?
Oh yeah, no. The quotes novel anticoagulants
Like,
were available to this provider, but they were relatively new and expensive.
yeah. So, I mean, I don't know how to defend something like that because that clot that you're talking about probably was not portal. Was it SMA maybe? Because you're talking about mesenteric artery being in trouble, right? It was in SMA. So Coumadin usually doesn't work well with that. So I think the patient was right to refuse that crap because it wasn't a quality treatment anyway. To me, I have a case right now that we do infusion and factor 10A inhibitor, and he gets infusion of Remicade, expensive or no expensive. How do you put a price on people's life? You have to have an agreement with it.
Mike, I think I missed it. Was there an informed refusal obtained? Or was there counseling and did they have documented counseling of the patient?
No documented counseling. There was a signed refusal in the chart with no explanation, and certainly no alternative treatments were ever offered to this patient. At least not in writing and according to the testimony. The bottom line was that this was an example, a really good example of a provider getting into a piss and match with a patient. It was just, I mean, I can't describe, there's no better way to describe this as much as I would like to describe it differently. That's what it was. The patient disagreed with the treatment and the doctor dug in his heels.
Because
and he did it in writing. He did it in writing.
Yeah.
My way or the highway, more or less, in writing in the chart.
We have to remember that our patients are our captive audience. They cannot just go on a Friday night to the urgent care center or the emergency department because they have an ache or a pain like they would have in the community. And that makes us really responsible, more so than in the community, if somebody were to see us in the emergency department, for their outcomes in their care. And most importantly, for, again, that patient education or informed refusal or informed consents. It's just so important because they can't do it on their own.
So, Lori, if I can, just to follow behind Michael when he talked about what the provider wrote in the chart, it leads me to think, and maybe that's part of a case, some case studies too, is you know, a discussion. And actually, we may have had someone speak on this, but what did you write it? What did you write in that chart? Did you really mean that? You know, sometimes what we're documenting, what we say and what we document, is not necessarily in line with what our intended goal is as a clinician, and then you put it in the chart, and obviously you guys know because you do, you know, service experts. But when we get in court, that doesn't look very well.
Right. Right. Okay. It's 5:30 here, so it must be really late for you guys on the East Coast. Anyone have any other comments that we could share?
Just that I thought vaccines, it's state by state. I think I put a link in the chat. This is for COVID, this link, but my understanding was that it differs state by state by state, whether you can waive the parental consent for a minor.
Ah, great. Thank you for that. I
Yep.
did see your link there. I didn't know what it was for. Thank you. Well, I thank everybody.
Is Patriots Patrick Kraft? Is that Patrick?
Yes, my phone keeps saying I'm Patriots. I'm sorry, and I keep having
no,
to change it.
No worries. I just want to know who to contact since you've got a bunch of good cases. We'll get you involved with the next one of these. I want to know if people are interested in this sort of a forum happening on a periodic basis, maybe quarterly or every couple of months. Show of hands or something if you're interested. Is that a good idea? Okay. And
Very good
From each
idea.
other.
and I
Yeah.
put my my email right now. It's very simple. SSNAG yahoo.com. And if you're interested in editing cases like this and trying to get it sooner or later into a book format, I think that this is an idea whose time has come, and I can't do it alone, frankly. And so if people are really genuinely interested in this, I will work with you. I guarantee you I cannot do it alone, but I will be willing to work on this project. And so please email me if you are interested. Fritz, I saw you, so thank you very much. And if people are wanting to be in touch with me about this project, I might put out an email seeking stories. I think it's something that we could maybe ACNA and ACCP could team up on or something. Anyway, just a thought. I think I've thought that we've got really good and interesting, fun and heartwarming and tragic cases that, and more importantly, if you wish, stories that the general public will also be interested in out of correctional medicine. Thank you very much for attending. I really appreciate the showing, and thank you, Lori, for helping us make this a possibility and keeping me on mute almost throughout. Thank you.
My pleasure. My pleasure. I hope we do this again soon.